Go ahead.
Good morning, everybody. Thank you for taking the time to join us for the PQMD special COVID-19 Pillar Talk webinar series, made possible in part from a generous donation from Pfizer. Today, PQMD, in collaboration with the World Economic Forum, brings to you a group of thought leaders who will share their insights about COVID-19 vaccine opportunities and realities. This is a two-panel event. So I hope you can join us for this panel and then the next one, which will happen directly after it. I'm Elizabeth Ashbourne. I'm PQMD's Executive Director, and I want to welcome you on behalf of our entire team. PQMD is a global alliance of international NGOs and leading healthcare companies committed to advancing the role of quality product donations worldwide. The World Economic Forum is an international organization for public-private collaboration. The WEF, as it's known, has been around for 50 years and engages the foremost political, business, cultural, and other leaders to promote values of stakeholder theory. You may be familiar with their annual meetings in Davos, and for the purpose of this webinar, it should be noted that Davos is the place that saw the birth of Gavi, the Global Fund, and CEPI, two of which you will hear from today. Very quickly, I wanted to review some housekeeping rules. Please type your name and your organization in the chat box and let people know that you're here, let people and your colleagues know that you're here. Because of the large audience and the format of the webinar, all participants are muted and videos disabled. I will share the link of PQMD's online community of practice into the chat box, as well as the website information for PQMD and the World Economic Forum. And lastly, we will be recording both of these sessions, and it will be available for your review later this afternoon on the community of practice and also on our website. So now I have the pleasure of introducing our moderator for this session, Mark Chataway, who is a longtime advisor to PQMD and an expert in policy analysis and development, opinion research, and communications. Although he was originally a journalist, Mark started working in public health. Whoa, sorry, excuse me. One moment. That, whatever you just put up, thank you. Sorry, that just switched the screens. So Mark started working in public health in the early days of HIV epidemic in the US. Since then, he has worked on vaccine and immunization issues and relevant policies around the globe. Mark is the director of Hydera CYF, a consultancy based in Wales, and co-chairman of Baird CMC, a global consultancy group owned by 40 shareholders in over 30 countries. We are thrilled that Mark has agreed to moderate this double panel webinar. And with that, I would like to turn the program over to Mark, and also very exciting to let you know that we are introducing some new technology into this webinar, and we hope you will enjoy it, and Mark will explain it right now. Thank you.
Lovely. Thanks, EJ. So lovely to have you all with us. It's going to be a fascinating discussion. That slide you can see up there on your screen, I hope, is how you can join in the discussion. So there's two ways to do this, and then I'll introduce our first panel and I'll introduce our first question. There's two ways for you to join, one on a computer or a tablet or a phone or any browser you like. You go to slido.com and you put in this number. It'll ask you for an event number, and you put in 46337. And you will go straight to the page where you can ask questions and take part in the questions we're going to ask you. The other exciting thing is when you see that other people have asked questions, if there's one you particularly want answered, you just hit the like button and it'll come to the top of our list. So we're going to go to the screen occasionally, check in and see what you most want us to discuss. So what we discuss will be guided by you, and if it's dull and incomprehensible, you know that you are to blame because you haven't taken part enough. The other option is you can take a picture of this QR code using any QR reader on your phone or tablet, and it will take you immediately to the right spot. So please do sign up for us because we have a question for you, which I would like you to answer as I introduce our panel. What I will do is switch to this so that even though the slide is there, you can still see me, but you can see the registration information. And what I would suggest is that before I introduce the panel, Jen, we might just quickly show them the first question on the shared screen slide. So can we do that? Yes, there we are. So this is the first question. And if you can go to Slido and type in a few words, we will see a word cloud, and that will help us as a panel to understand what your work and your interests are and to tailor what we say accordingly. So if you go to Slido, that would be lovely. Great, let me introduce our first panel. So as EJ mentioned, we have two panels. The first one is going to look at the kind of global system for vaccines and how that system is responding to COVID and how it might in the future. And the second panel is going to look at the vaccines in development, how industry is responding, what industry is doing about access and about collaboration and working together. So that's our 2 hours, but our first hour is going to be this first panel. We want it to be super interactive. We have a list of things to talk about, but you can change that list by asking your questions and voting them up. So joining me in this panel is Arnaud Bernard, who is the head of Shaping the Future of Health and Healthcare at the World Economic Forum, somebody who'll be known to many of you. We had a discussion within the team as to whether he was the father, the mother, or the midwife of the international vaccine architecture, but he's certainly largely responsible for chunks of it. So it's a great pleasure to have him with us. And then joining us from Washington, D.C. is Dawn O'Connell, who's head of the U.S. office of CEPI. You will hear a lot more about CEPI in a minute. And I have a question for you, but CEPI is a new part of the international architecture, a relatively new part, focused on preparing for epidemics and trying to combat them. And then we have Sophie Matthewson, who's a specialist in the policy team at Gavi. Many of you know Gavi, the Vaccine Alliance. Sophie is going to talk to us about the work that Gavi and CEPI are doing together on vaccines. And then we have Dr. Tallulah Oni, who is a public health physician and an urban epidemiologist, and who ran a vaccine trial quite recently on tuberculosis, so has the added advantage of being someone who has faced the issues of running quite a big trial in a difficult area with lots of comorbidities. So I'd like to welcome our panel. And I think we still have the screen active. Wow. And you can see, I think everybody can see what people are doing there. So the words that jump out are equity, vaccines, policy, safety, global health. By the way, I apologize if any of you can hear a snoring sound. It's not me, it's not the participants, it's my dog who refuses to be moved. So if you hear snoring, do not be inspired, do not fall asleep, it's the dog. And look at that, collaboration and hesitancy. So that's really helpful. We might check back on that screen a bit later on. But Jen, if we could, I'd like to ask everybody another question. And we will look at this screen in a few minutes' time. The question is, how familiar are you with the institutions that are part of the global architecture for vaccines? And so if you'd like to vote on that for us, again, that'll help us in our discussion. So if we can we show that one, Jen? Oh yes, people are voting on it. Wow, so even before we've shown it on the screen, people are voting on it. Excellent, great. So for those of you who are on the system, you will see this question and you get to vote on it. And preliminary results are that we have a good level of basic familiarity. So that's excellent, lovely, good. So if we can start out on our panel, I'd like to start out by asking all of you about the collaboration we're seeing. I suppose for people who are not part of the vaccines world, collaboration sounds like an easy thing, but what we're in fact seeing now is the international architecture and companies working together in a pretty unprecedented way, right, Arnaud?
Yeah, thank you very much, Mark, and thank you, EJ, for inviting me to the panel today. The collaboration is really problematic at this point in time. I need to say, I think on one end, we've got those instruments that have been born 20 years ago as a Global Alliance for Vaccination and Immunization, one of the most remarkable organization on earth. Gavi has been instrumental in children vaccination for 2 decades, 700 million lives, 700 million children being vaccinated and saved arguably more than 10 million lives. And CEPI, which is a research organization that was launched in 2017 in Davos, are certainly great examples of collaboration. On the other end, we've seen also a flurry of bilateral agreements between those rich nations and those innovators of vaccines. And those bilateral agreements are not precisely demonstrating a strong desire to collaborate, but it's more of a nationalistic approach to protecting your own population by splashing very large amount of money in support of securing very large doses, number of doses of vaccines in case they would succeed, and do that irrespectively of that. Gavi and CEPI have been trying to promote something very different, which is a pool procurement mechanism that would serve the world in its full extent, and where allocation would be made not based on how rich your nation is, but how much the populations need the vaccine, starting with healthcare workers, the older population, or the more vulnerable citizens that are suffering comorbid conditions that put them at risk. So you've got two schools of thought at this point in time, and I hope that with the likes of CEPI and Gavi and what they're doing in the management of the COVAX facilities, that particular pool procurement I was mentioning, I hope that we still have a short window to actually repair what's happening.
So I think Dawn and Sophie, this is the time to bring you in and to talk about how you're working together. Just so you know, about 60% of our audience say they're pretty familiar with the work you do, and about 25% say they're quite unfamiliar. So I think it's safe to guess that people have a basic knowledge of, many people have a basic knowledge of what Gavi and CEPI do. But tell us how you're working together in the context of COVID, and especially how you're working together to benefit countries that may not have the kind of infrastructure that the US and a few European countries have. Do you want to go first, Dawn?
Sure. Thank you so much, Mark. And thank you, EJ, for having this forum and having me as a panelist. I'm pleased to be here and very impressed by this technology. I'm taking notes as we go. This is the first time I've seen this sort of interactive approach. So thanks for all of that. Mark, and thanks for the good question. So CEPI was formed just a few years ago to accelerate R&D and coordinate R&D to prevent an epidemic. So we were quickly being tested now in this pandemic situation. We currently have a portfolio of 9 vaccines that we're funding. And we started very quickly. Within 12 days of the genome being released on the new coronavirus, we had a funded partnership already and quickly pivoted and were able to add several more. Of course, that's not what makes CEPI unique. What makes CEPI unique is that we want to make our vaccines available for the world's population, for those that need it, when they need it, as they need it. And that's where our relationship with Gavi has come in. We have taken on the R&D pieces to make sure that there are good candidates available for a fair global allocation system. But Gavi really has the infrastructure in place to help us manufacture and deliver those vaccines to the right populations in the procurement facility, which I'm sure Sophie will share some details about in a minute, to bring countries in an advanced purchasing arrangement to be able to supply these vaccines to the world as they need them. So Sophie, I don't know if you want to fill in, but just to say, as one of CEPI's big roles is the R&D piece, is making sure that the candidates are there. Gavi has built some of the other infrastructure. Sophie?
Yeah, and just to echo, thank you very much for the invitation and for the opportunity to talk with all of you about the work that we're doing with our partners. So I guess it's worth noting that Gavi has been in discussions with CEPI really since its inception, and probably we would have anticipated collaborating on a different kind of pathogen from elsewhere in CEPI's portfolio. So to some extent, our collaboration in COVAX really reflects discussions that we had begun to have about how CEPI's investments are kind of advancing R&D for vaccines for epidemic diseases, but also recognizing that the architecture that we had needed a little more thinking to prepare us for emerging pathogens. And so the discussions that we've really been having around COVAX, also with WHO, have culminated in sort of setting up a collaborative way of working, which is really new under the vaccine pillar, with kind of joint leadership and really trying to play to our comparative advantages and areas of expertise. And so one of the things which Dawn has mentioned is the COVAX facility, which was sort of established in the summer, and we've been in very close discussions with countries, both self-financing countries and countries which historically have been supported by Gavi, and a number of other countries that the board has identified as being a priority. And the aim is to really have an ambitious approach to kind of pooling a portfolio of vaccines, drawing on the investments that CEPI has made, but also recognizing that there's a huge amount of R&D underway, with a view to being able to secure a proportion of those doses through advanced market commitments and through other investments, so that we can guarantee that volumes will be available for delivery at global scale, but with a focus on the highest priority populations, such as healthcare workers and other populations known to be at greater risk.
And I saw Seth Berkley, the head of Gavi, tweeted yesterday that 173 countries, I think, countries and territories maybe, are now in conversations with Gavi and CEPI over this COVAX facility. But one of the issues is there's a certain tension, isn't there, between all of us wanting to work together and the portfolio approach there, and countries wanting to make sure that they have enough vaccines for themselves. So could you tell us a bit about how Gavi's sort of in the middle of that, and whether you have a solution to it, with no pressure, obviously?
I think that's the kind of diplomatic challenge of this whole piece. But obviously, in terms of bilateral deals, we recognize that countries want to secure what's best for their population, that this is having a huge impact on their economies and health systems, and that there's a strong rationale to secure access to products that will help to mitigate and address the situation as soon as possible. But at the same time, countries that may be prioritizing particular vaccines for bilateral deals may be picking the candidates that ultimately don't deliver in terms of public health impact. So there's a sort of strong, I guess there are still strong arguments to be made that it's better to have a broader and more diverse portfolio of vaccines and sort of smooth the risk and make those investments as a global community, and prioritize the populations at greatest risk. Even as countries may want to make their own bilateral deals in parallel. And one of the questions that we need to address is how ultimately, once vaccines become available, once we have the supply of safe and efficacious vaccines that we need, how we reconcile the availability and the need to allocate in a way that's sort of fair and getting the greatest public health impact globally. And those are discussions which aren't easy, and they're still ongoing with WHO and with a number of partners and with countries. But we're trying to find a kind of middle ground which recognizes self-interest, but which also is able to deliver for global public health.
And I want to come back to this question of the bilateral deals in a minute, Arno. So I'll do that in a second. But I want to pick up on another point you made there, Sophie, about vulnerable populations. I can see people joining us all the time on the counter. So for those of you who are, I'm showing myself in this little box now because this is how you ask questions, and this is how you participate in polls we'll ask later on. So in a browser, sign up for Slido there. Scan the QR code if you have a phone, and it'll take you straight to it. You can ask us questions, and we will change what we're talking about to reflect questions. You can also vote on other people's questions and say which ones you want answered most. Also, just in the chat box on Zoom, there are links to all of the organizations who are part of this panel, and there will be links to the organizations, the industrial organizations, R&D organizations who are part of the next panel. So Tallulah, if I may ask you to come in on this question of how you make sure that a vaccine is going to work for the people who need it most, and then the even more tortured question of how health systems are going to bridge the gap between the people who do infections and the people who do chronic care, which we know in COVID is a gap that's costing us lives.
So yeah, thanks, Mark. I think I would start by prefacing that we know that the existence of a vaccine doesn't automatically translate into eradication. I think the polio example, just the announcement earlier this week about the eradication of polio in wild polio in Africa is, a monumental feat. It's not a new vaccine; it's been around for a while, and I think that is just to preface the fact that the existence of the vaccine, starting from the existence of a vaccine and ending out in eradication, is a complex systems challenge and not just a biomedical one. I think I would say there were three things that were important to consider. And this, I'm basing this from my experience of both clinical epidemiology of epidemiological transition, so the increasing co-occurrence of infectious and non-communicable diseases in countries that are rapidly developing. So we have this coexisting diseases that also interact, like HIV and TB. We know connected, for example, but we know that they co-occur in the same population groups as with diabetes and hypertension and cardiovascular disease. And we know that these diseases interact. We know they drugs interact. We know some diseases interact with other diseases, drugs. So their epidemiological concepts are important to take into consideration. The second aspect of where I come at this is from a perspective of how this is reflected in the in trials and in research. So if we are focusing on thinking about the importance of those epidemiological contexts, what do we know about the potential vaccine efficacy in the context of comorbid conditions? Are they represented in ongoing research, or are we going to get to a point where we have a vaccine that is efficacious, but then we are uncertain about the effectiveness in the real world effectiveness where these diseases are comorbid? So that's the first thing, epidemiological context. The second, which you challenged me on, is the health system. And this is an important aspect because we often find that the health systems are not sufficiently responsive to those transitioned, those epidemiological transitions. So, and this comes from how we're trained as a physician. You know, you're infectious diseases physician, so you see infectious diseases, and so the person in front of you is just the problem is infectious diseases, because your clinic is on a Tuesday. If they have diabetes, you know, that's a Thursday clinic, and that's over there in this other place that's got nothing to do with me, even though we know that has consequences. And one of the things that COVID has highlighted, we know that the risk of severe disease, for example, in people with, say, diabetes. The World Bank paper just came out today about a 48% increased risk of death in those with obesity. So we know these diseases co-occur. So we can't afford to think about the health system in the context of, well, is the vaccine being delivered in the infectious diseases by the infectious diseases people? Because we will miss the opportunity to think about the most effective ways of delivering that. And I would add to that it's not just to do with the effective delivery, but also, can we think about delivery of a vaccine in a way that mitigates the indirect negative impacts that COVID has had on other core health system functions? So we know, for example, you know, in the UK, we've seen a lot less in the peak of the pandemic, a lot less heart attacks and strokes presenting to healthcare. Those are happening anyway, but we know that there are negative impacts. There are concerns about tuberculosis care, other chronic disease care, immunization programs, etc. So we know that the acute emergency and the nature of the pandemic is such that a lot of resources were diverted into within the health system dealing with the pandemic, which is necessary. But can we think about delivery in a way that is part of comprehensive health protection that seeks to actually address and reverse some of those indirect negative impacts? And I think the third thing I think it would be important to mention, and perhaps we'll come back to, and then I will stop talking, I promise, is that in all of this, and we've started talking a little bit about prioritization, vulnerable groups, etc. We also know that in the same vulnerable groups, there are issues around trust in communities, in terms of trust in governments, trust in science, trust in healthcare, and this is not unwarranted because we have a history of certain, you know, from the Tuskegee trials in the US, you know, we have a history of particular groups that are vulnerable, particularly communities of color that are that may not have the trust. So if we talk about, well, let's identify people who are particularly vulnerable to COVID based on what we see in terms of incidence and mortality, well, we have to do it in a way that recognizes the importance of trust and learn lessons from previous epidemics, but also from what we're dealing with at the moment with COVID, and engage with the community assets and the leaders within that to build that trust. Otherwise, there is no objective, or we know better, and we're here to look out for you. You know, we may not have the uptake that would be required, which would be a shame. So I think that was just just my initial reflections.
And actually, Arno, I'm going to delay coming to you on the bilateral deals for one more minute, because Tolu, that ties to a question we've had from Doug Huber, who says, how do we prepare for vaccine hesitancy, and what role can faith-based organizations and religious leaders play in this? So this ties directly to that issue of trust you talked about. And I wonder if you'd like to talk briefly about that, and then I'll come to you, Sophie, as well, if I may, because I know Garvey has worked with faith-based groups and has some ideas. So,
yeah, no, I mean, I think it's an important thing to reflect on, not just at the point of vaccine delivery, by the way, and I would say this across the whole process of vaccine development. So right from vaccine trials. So it's easy to fall back and say, you know, there's some people, they just don't want to engage in trials. We just can't get. It's like, well, how are we engaging with community representatives and the leaders in the community to participate? And so if I reflect on our experience of the TB vaccine trial in South Africa 10 years or so ago, there was a good year and a half head. I mean, obviously we don't have the advantage of that time here, but going into the community and engaging through understanding what the structures are in terms of the leadership, and engaging with the structures to understand, well, there's this trial, this is why we're doing it, this is what, you know, and just give the process time to breathe, and give the leaders and the key influential people, and that might be faith-based communities, that might be local NGOs, that might be, it might just be personalities or characters within the neighborhood who play an important role in understanding and therefore influencing others. So really important to accelerate that and innovate in that space across from vaccine development right through to delivery.
And Sophie, I mean, you're right at the center of dealing with these questions, and Doug asked a follow-up question actually about misinformation and misunderstanding. So Garvey's been right at the center of these efforts to combat misinformation, concern by parents and others. How do you see that feeding into the discussion around COVID vaccines?
I think just to echo Talila's point on the importance of community engagement around trials, I think we need to start building trust in the context of research, but really use it as the basis of also thinking about building demand generation in communities, and really I mean, I think there's probably, you could have hours of discussions on misinformation hesitancy, but sort of recognizing that there may also be different factors that are coming into play. It may be about access to vaccines. It may be about the quality of services that are provided. It may be around you know, the acceptability to the community of the type of services. So sort of recognizing that to be able to really provide access, particularly to children or parts of the community that may not regularly be reached by the health system. Sort of, we need to understand a bit where we're failing in terms of implementation, and also think about, you know, what do we need to do to build demand? How can we build trust in health systems and in health providers more broadly? And then what are likely to be some of the challenges around COVID vaccines that might make them a lightning rod for some of the challenges that we face elsewhere, but also an opportunity to sort of start to improve the system that we have, and address some of these issues in the longer term, so that adults get vaccinations as well as children, and we really start to think about vaccination as being part of a broader disease control approach, and part of having a functioning health system. And I think that's sort of an ambition we need to set ourselves in the longer term.
Yeah, and that whole question of adult immunization is something we might come back to. Arno, let me turn to a different type of trust. So ideally, we'd have a global system of trust in which we pooled the risk and we assessed who needed vaccines most, and we had a portfolio of vaccines so that people were investing in different kinds. That's not what's happening, is it? We have these bilateral deals. And when we were talking before this panel, you gave me some truly staggering numbers on what kind of production commitments have been made and what they may say about how much trust we should put in those commitments.
Yeah, and I think the matter of trust in governments in general is a broad topic. And when it comes to vaccine hesitancy, by the way, we just commissioned a survey with Ipsos, 20,000 adults in 27 countries. And the question was, if there would be a vaccine approved by your government, would you take the vaccine? And the average is okay-ish, 74% of those 20,000 respondents. But it goes from 97% in China to 54% in Russia. So I think that's the first element of a response when it comes to trust in governments. Obviously, those governments, they have to do also what they have to do in terms of the political liability and the liability they have with the citizens. So this is where we see that frenzy of cutting a number of bilateral agreements. As you know, there are 173 vaccines currently being advanced, and 31 of them are in clinical stage. and of the 31, 7 are in phase 3. Of the 7, 5 are outside of China. Now, if you look into the 5, there are Moderna, Pfizer, Sanofi, AstraZeneca, and J&J. Those companies have collectively signed agreements or pledges to actually allocate those vaccines to high-income countries in the magnitude of 2.5 billion doses plus. And it's still counting, right? It's happening every day. You see a deal a day. I mean, and that's happening with the US. That's happening with UK. That's happening with the European Commission. We've seen that happen in Japan. We've seen that in Australia yesterday, and it's still counting. This is in a context where last year the total manufacturing of vaccines outside of season flu of the planet was 3.5 billion, largely so distributed by channels like Gavi and UNICEF. So, you know, where are those 2.5 billion going to come from? Well, what's happening is, and I can tell you, we were talking to a very, very small vaccines manufacturer today. I won't name it, but you need to know that they are producing 10 million doses annually. 10 million doses. They have already been approached by 3 of the companies I told you about. There's not going to be much that's going to be left when those innovators will have secured or actually hijacked manufacturing capacity that is present in the developing countries. By the way, 70% of the vaccines manufactured on Earth come from the developing countries' vaccine manufacturing network. They are not manufactured in the West or the North. I mean, they are manufactured in India, they are manufactured in Brazil, they are manufactured in South Africa, in Korea, in Malaysia, you name them. And those capacities are being hijacked. Obviously, they are being increased by way of running free shifts and so on, and by way of making investment, but they are being hijacked in support of bilateral agreements. And that's a very, very, very big worry, because if you look into what has been at this point in time committed to COVAX, the only deal is a 300 million dose deal between CEPI and AstraZeneca / Oxford Serum Institute of India vaccine. So 300 million doses, 2.5 billion doses, and a big challenge on where the increased manufacturing capacity is going to come from. That's where we believe at the World Economic Forum that if the pooling mechanism like COVAX is not further accelerated by a manufacturing capacity pooling in support of COVAX, we are not going to go terribly far.
So, Dawn, I'm going to come to you in a second on this. I just want to remind people of 2 things. One is I've just put a poll on the Slido app, the link to which is here, the QR and whatever, asking how likely our audience would be today to take a COVID vaccine if it were approved this year. So if you'd like to vote in that, I'll come back to the results in a second, but it's on the app now if you're signed in, and of course you can continue to ask the questions. The second thing to remind you of is I saw while you were talking, I don't know, you might not be in gallery view, but I saw Professor Raul Machado Neto, who is from Instituto Butantan and is on our second panel, nodding and shaking his head furiously at different points. So you can be sure we will come back to this question in our second panel, which has Professor Neto, Dr. Julia Spencer, Dr. Isabelle Deschamps from Julia from Merck, MSD, and Isabelle from Sanofi Pasteur. So 3 big important industrial and R&D players who will come back to this. Dawn, Arnaud has highlighted a real problem here that I know CEPI and Gavi are trying hard to address. Where do you think this will come out to?
Thanks so much. That's a great question. And it's one that we're working on every day, of course. So one of the things that we did initially, I'll take even a further step back, and of course we'll invite Sophie to to jump in. But one of the things when we looked across the ecosystem, when CEPI, which was designed to respond to epidemics, which is in our title, when we realized that this was becoming a pandemic, and we were choosing which vaccine candidates that we would fund, initially we were funding the ones that were most likely to be a good platform for a coronavirus that we already had in train, that we could pivot very quickly for a regional outbreak, like in Wuhan, which is what we were seeing when we were making our first investments in January. Very quickly through the end of January into February, we realized we were reaching a much more global stage of the virus, and we were seeing an actual pandemic. We began to pivot to fund vaccines that could be manufactured at large scale. That wasn't, an initial priority because we were seeing a very localized outbreak initially. So as we began to pivot and to look and to see, okay, not all of these new technologies that are coming out for the first time that are very exciting have been manufactured before, have been manufactured at scale before, have been licensed. So there's a lot of steps here that are going to be very new in the work that's happening, and some of these bilateral agreements that you're seeing with some of these companies aren't necessarily going to be the ones that are going to produce the large the large capacity of doses. So there's that issue. So we've been evolving as we've seen the outbreak evolve to try to accommodate this. We very quickly, when we realized the full scale of the outbreak, put out expressions of interest globally to all of the manufacturers that we could find that were regionally situated to at least identify sources of manufacturing for the CEPI-funded vaccines that would be located in each of the regions of the world and globally stratified in that way. And identify and begin to reserve the capacity. But when you get into the reservation of the capacity, when you look across the ecosystem, this was something very new. CEPI was founded to do the R&D and scale-up manufacture of our candidates, and other pieces of the ecosystem were designed to distribute the vaccines, but who was going to manufacture them? This is one of the first tests, I think, of this new architecture, Mark, that you talked about at the beginning, was who fills this manufacturing gap? So that's one of the things, and the reason why I was going to invite Sophie, of course, into the conversation. We've been in discussions with Gavi. Who funds that? How do we, we've identified the manufacturing capacity, we hope, but how does that get realized? They're used to doing a very different sort of vaccine campaign. So this is sort of a new test for all of us. And one that's very challenging. And then Arnaud, this doesn't even get to the point that you've made, which is so many of those doses are already spoken for, and how we accommodate and account for those that are included in the bilateral agreements. What I would say the most important thing is how we deal with the doses that are manufactured first. All of the doses that you mentioned in the billions, to your point, aren't going to come across the manufacturing line in the first quarter of next year. And so what's critical and important in the COVAX space is how we distribute the ones that we have access to that come across first. But Arnaud, it looked like you were trying to get in. I'll pause.
No, I wanted to, well, first fully agree with you, but also further explain my point. My point is that obviously of those 5 vaccines, not everyone is going to go across the finish line. Maybe if we're fortunate, we got 2 or 3. So that means that some of those manufacturing capacities have been locked in for vaccines that will fail. And when I talk to Serum Institute of India, what they're telling me is that to repurpose for another vaccine is going to take 6 months. 6 months is what the world will have taken by way of implementing bilateral mechanisms as opposed to multilateral mechanisms. So I think that's a fairly profound issue.
Yes, thank you, Arnaud. I'm going to come to you, Sophie, in just one second. Quickly to have a look at the results, if we could just flash up the screen. Among our participants, or at least among those of you who are responding to the poll, you have high confidence. So if a COVID vaccine were approved this year, no, I suppose that's not true, but nearly all of you would take it, I guess. 90% of you would take it. So among this audience, there's a high level of confidence. Probably, Arnaud, not a typical response based on your polling and other work we've seen. Sophie, do you want to jump back in on the question of supply and how we're going to rebalance it? And then I want to deal with a couple of questions that have come in. So Sophie.
I mean, I think the kind of critical points have already been covered, but just to say that we're part of the urgency at the moment for getting countries to commit to the COVAX facility, and obviously this is in addition to the countries that would already be eligible through the AMC, is to give us or give Gavi and our partners the sort of financial resources that we need to deliver on a lot of the deals which are being discussed at the moment, and the engagement with manufacturers. And then I think recognizing that we will be operating in a supply constrained environment, it's also kind of working with our colleagues at WHO and working with sort of all of the epidemiological evidence that's been generated on what will give us the greatest return on investment from a public health perspective with those early doses. And what can we do, thinking about the public health value of vaccination access sort of in the early period, and then how, as we transition to a slightly more hopefully a kind of normal operating environment where we've got a mix of different vaccines with different profiles that might be great for some populations, not so effective in others, or that may be easy to deliver in more challenging situations, in humanitarian emergencies, because they're better out of the cold chain. Really starting to think about what the supply environment looks like, what the different scenarios would be for delivery, and then how can we expedite all of the steps that would usually require kind of a long lead time and planning to make sure that sort of as soon as we have the doses, the countries that we work with can deliver them. And we also learn a lot from the experience in 2009 around how the delivery challenges affected the value of the vaccine by the end of the pandemic.
So Tolu, that's exactly the point I want to come back to you on, and it's a point that actually addresses a question that's been asked of us. It's exactly that. How sure can we be that the delivery systems will exist, especially as we sort of move in fits and starts towards universal health coverage, but we know that the people who are at the highest risk are often the people who have the most trouble getting access to healthcare.
Yeah, I think just to build on Sophie's point, maybe something that we haven't explicitly stated, which is the trials are ongoing. Their use will depend on what the endpoints are, right? So if we, and what the goal is. So if we're talking about trials that are we talking about trials that aim to look at impact on deaths and severity? Are we talking about trials that are looking at infectiousness? Because that has implications for how you interpret and the follow-on into delivery. If, for example, you have a vaccine that is but only focused on only effective in reducing deaths, I think that would be a good outcome, obviously, but may not be sufficient in the context of achieving herd immunity and reducing transmission if there isn't sufficient impact on infectiousness, for example. So that has implications for, and I liked what Sophie mentioned in terms of the different scenarios and the possibility of having a multiplicity of not just mechanisms, but of options and optimizing for the specific context, knowing that if the key issue in a particular context is ensuring that you reduce in infectiousness because of the conditions within which people live, etc., then that might have an impact that should have an impact on the nature of the vaccine and the delivery mechanism. I think the one thing, I don't know if I'm directly answering your question or just saying what I wanted to say anyway, which is that the other thing I was speaking on vulnerability and that I thought about when Sophie was talking as well, is that sure, there's some environments that are not modifiable, and so we have to look at adapting the choice of vaccine and the delivery mechanism to that environment. But we must also remember that there are lots of environments that are modifiable, and so when we think about improving health outcomes, I think I mentioned earlier, I meant to, that the primary goal isn't vaccine delivery. The primary goal is improving health outcomes. And it sounds like I'm saying the same thing, but it really isn't, because if we look at, well, then if we identify people as vulnerable and we say, well, why are they vulnerable? How much of the vulnerability in terms of exposure and susceptibility is modifiable? Then the vaccine, we should be thinking about the vaccine delivery mechanisms in a much more comprehensive way. Otherwise, we're not being efficient.
So Dawn, as we go from that, we've touched on this point several times, that 200 vaccines down to a more manageable portfolio of candidates, and then we decide where to invest. How much relates to the issues Tola was just talking about? How much relates to, is it a multi-dose vaccine? Is it single? Can it be administered through the systems we have? What do we know about how it functions with comorbidities? You're an essential part of that winnowing down process. How does it play out?
Absolutely, and I think that with the points are critical. We're sort of dealing with the vaccines that we have right now, and the ones that we were able to identify very quickly. Of course, now we have the 200, and we do something called active portfolio management, which is a very dynamic process where we're constantly analyzing and reviewing the vaccines in our portfolio to make sure that we are continuing to support successful ones that are going to make sense to deploy in the field. And so that's one of the pieces. But what we are discovering is that because this pandemic came up so quickly, because we had to pivot so soon, because we had to deal with the vaccines that were in the pipeline and find the ones very quickly that could make a difference, within this first year, some of these first wave vaccines aren't going to be our best ones. So we've got two challenges. One is taking the ones that we do have and figuring out which ones make more sense for the elderly. Do you give them the 2-dose or do you give them the 1-dose? Which regions make more sense for the ones that require the cold chain? Some are going to just ease symptoms and aren't going to prevent you from getting COVID, but they're going to prevent you from dying, which was just mentioned. And so what populations make sense for that to go in? Is that the young and healthy? So that there's going to have to be a stratification of the current vaccine candidates that we expect to come through this first wave. But we are also, one of the contributions CEPI's making, of course, to this outbreak is looking at the second wave of vaccines, those that are going to be, improvements upon the ones that we currently have, those that are going to go to 1-dose, those that aren't going to need cold chain. It looks like COVID's going to be around for a long time, unfortunately. And so investing in this next wave is going to be critical. But stratifying this first wave and figuring out which populations need which what sort of vaccine that we will have access to quickly is going to be critical, and part of the process that we're engaging in right now with Gavi and others.
So Steve Penfold asked this question: are we setting, given the damage to the global population and the economy to date, are we still really expecting a lot of these vaccines to fail? I suppose we are, aren't we? Because you would know better than me, Dawn, and we'll touch on it in the next session, but the vast majority of vaccines that anybody tries for anything don't work at all, right?
Highly complex, highly risky, and many fail in phase 3. And I think Arnaud was listing at the beginning of the session, those that have come as far as they are. We've got, the handful that are in phase 3, which feels very optimistic to us, but also we shouldn't lose sight of the fact that, that's a failure point for a lot of vaccines that we've seen previously. So yes, it's important to have several good candidates in the pipeline moving quickly, because we might come down to just 1 or 2 in the end that we feel is safe for the general population.
So we've got a couple of minutes left. I want to ask Sophie and then Arnaud 2 things, and Arnaud, if there's a point you need to make, we'll tag it on to the end. But
no. That's no. But I will follow up on your comments.
Well, would you start? You start us off, and I'll come to Sophie with the same question.
No, please go on, Sophie. Go on, Sophie.
No, Arnaud, you start. How?
The point I wanted to make, and that's going to be over. I think, ironically, we're going to start vaccinate people with vaccines we don't really know the effect in the long term. And one of those endpoints is going to be about the preserved level of immunity after 1 year or 2 years. Okay, by definition, the trials won't have concluded on that, because we want to start vaccinating as soon as possible. So we may have we may have a good understanding of safety and immunogenicity, but the durability of the protection we may simply not know. Meaning that, and considering also what I was telling before, which is unlikely that the global population can be vaccinated in 1 year, not even 2 years, not even 3 years, I think it's the vaccine that has been very much so presented as a silver bullet is only one of those instruments as part of a portfolio of response, which is especially true as governments will increasingly resist lockdowns and isolation measures. So I think I can't stress enough the fact that we could have another discussion in the next hour on the need to advance better diagnostics.
Thank you, Arnaud. I mean, that's a really good point. Sophie, I want to leave you with the last word on an issue we haven't addressed at all so far. We've been talking a lot about COVID vaccines, and we've been talking about the deployment of those. But this pandemic is interfering with the deployment of the vaccines we have, right, in multiple ways. And so we mentioned the polio success earlier, which is wonderful. The polio anti-polio efforts in Afghanistan and Pakistan are under threat, and routine immunization appears to be suffering globally, right?
Yeah. I mean, I think this is probably too complex to describe succinctly, but we've seen the impact in terms of supply, so shipments and our the global supply chains, and the impact that we've had just on the fact that things aren't moving around the world in the way they do usually. I think also in terms of the healthcare worker and the impact that the health system has suffered as a consequence of COVID, and as a consequence is, the human resources element and of health, and the impact that the COVID outbreak has had in different settings, and also trust and sort of communication around the importance of routine immunization, which there's been great modeling done by the London School, which has sort of shown the value of keeping routine immunization going, and despite the fact that COVID is obviously having a big impact. So we're sort of closely monitoring the impact in different countries, and sort of seeing how that evolves alongside the epidemiology. But also I think we've learned a lot in the last 7 months on sort of what countries need to mitigate some of these issues, and how we can try and limit the impact. But we are aware that there will be a kind of long tail of disease that's a consequence not of the COVID outbreak directly, or pandemic directly, but as a consequence of the disruption that it's caused in people's lives. And I think we're going to need to be prepared to build things back, and to also think about how we kind of reaffirm our commitment to reaching the lost children, and everything else that has been motivating our work for the last few decades.
Well, look, the sign of a great discussion is that you feel so much has been left unsaid. And I feel that an enormous amount has been left unsaid. But I'm deeply grateful to my panel for all that has been said, and for such a fascinating discussion. It will continue. So if there are questions we haven't answered, which there are, unfortunately, but there are questions we haven't answered, that will continue on the PQMD community of practice. And we'll do our best to pester our panelists where we need to get answers. So I'd really like to thank Tallulah Oni from Cambridge University, the MRC Epidemiology Unit, a public health physician there, Arnaud Bernard, the head of health and healthcare at the World Economic Forum, Sophie Matthewson from the policy team at Gavi, a specialist there, and Dawn O'Connell, the head of the US Office of CEPI. Wonderful discussion. Thank you so much. We're going to take, because it's 4 o'clock in Wales, because I'm Welsh and because I'm the moderator, we're going to take a 5-minute tea break now, because at 4 o'clock, obviously, one has to take a tea break. Right, Tolu? I'm looking for support.
Absolutely, absolutely.
So
I validate you.
A 5-minute tea break, and then we will come back with our second panel. You can see the panelists already online. We have Dr. Julia Spencer from Merck, MSD, Dr. Isabelle Deschamps from Sanofi Pasteur, and Professor Raul Machado Neto from Instituto Butantan, ready to go in 5 minutes. I hope you will join us and sign up for Slido In the meantime, Jen, maybe we could leave people with the Slido information while they make.
Start our second panel. Good afternoon again. We are so glad to have you join us for this PQMD special COVID-19 webinar series, made possible in part from the generous contributions from Pfizer. In cooperation with the World Economic Forum, PQMD is facilitating this discussion on development and implementation of a vaccine for COVID-19. This is the second of a two-panel event, and if you are just joining us and are unfamiliar with PQMD and WEF, we invite you to learn more about these global alliances on our websites listed in the chat box. I am Elizabeth Ashbourne. I'm the Executive Director of PQMD, and on behalf of PQMD, we are so pleased to welcome you or welcome you back if you joined us for the first panel. Just a reminder that because the audience is very large and the format of the webinar, all participants are muted and videos disabled. You will find the link for the PQMD's online community of practice in the chat box and invite you to join if you have not done so already. We are recording this session and we recorded the last session, and it will be available later this afternoon for your review. And go ahead and let colleagues know that you're here, and please type your name and organization in the chat box if you haven't done so already. I am turning this over to our moderator, Mark Chataway, an expert in policy analysis and development who has focused extensively on vaccine issues around the world. And he will also be introducing you to our new technology, which is hopefully will encourage more interaction between the participants and the panelists. So Mark, over to you, and for the introduction to Slido and then also the participants. Thank you so much.
Thank you very much. It was a wonderful panel last hour for those of you who were with us. As EJ said, many more people watch these panels afterwards than participate in them live, but on this occasion they're going to feel terribly left out, because if you participate live, as I hope you will, then you get to take part in the discussion. So I'm pointing now at slido.com. If you weren't here for the first session, slido.com, you can go and enter that number, which will allow you to take part in our live polls, one of which I'm going to ask you in a second. Or you can use your phone or your tablet to just snap the QR code and it will take you straight to the right space. You can take part in the discussion. So I hope you will do that. I'd like to introduce our second panel. I know Dr. Julia Spencer of MSD, of Merck MSD, is having a bit of trouble with her camera. So Jen, our technical expert, I hope is on the case.
Yes, I'm chatting with her now.
Okay, great, which would be a pity because we'd like to see you, Julia, but let me introduce the panel anyway. Joining us from Lyon is Dr. I assume you're in Lyon, Isabelle.
I am, yes.
Is Dr. Isabelle Deschamps of Sanofi Pasteur. Isabelle has been working in the field of vaccines for many years. She's the head of global vaccines public affairs at Sanofi Pasteur. Joining us from Sao Paulo, I know because I can see him sitting in his office, is Professor Raul Machado Neto, who is the Director of Institutional Strategy at the Instituto Butantan. Joining us shortly on video, we hope, is Dr. Julia Spencer from Merck, known as Merck Vaccines in the US, known as MSD Vaccines in the rest of the world, where she's the Vice President for Global Vaccines Public Policy. So that's our panel, and we have quite an ambitious list of things to get through, but if you ask us questions, we will do our very best to make sure we adapt our conversation to answer your questions. And we had good questions last hour, so I hope you'll join some this hour. Let me ask you a question first, our audience. So on the Slido system, for those of you who are online, I'm asking you a question about how much you know about how vaccines are usually developed, tested, and approved. So if you answer that, that will help us guide our discussion. And in the chat box on Zoom, you can see both who's here. Great to have Mark Grayson, who used to be at Pharma, just joining us, I see in the chat box. But even more importantly, in the chat box, you can see the links to the organizations for which our panelists work. So that would be great. I'll show the screen in just a second. And Jen, did you have an update on Julia's camera?
Yeah, I'm trying to get it to work. I'm trying to.
Okay, very good.
I think what I might do is just quickly leave and come back in, and maybe that will do it. And I'll try to do that as quickly as I can, Jen. And maybe it was just a glitch.
Okay.
That's certainly the advice every IT support person gives me whenever I ask, which is, why don't you leave and join again? Let's have a look at our results screen while we're waiting for Julia to come back, Jen, if we may. So would you mind sharing the results screen? We're asking you to multitask on an epic scale here. Sharing the results screen from Slido. So what we ask people on Slido is, how much do you feel you know about how vaccines are usually tested and approved? It looks as if about half of you are fairly familiar, and about a third of you are quite unfamiliar. And then we have a few who say they're very familiar and very unfamiliar. Unfortunately, we have no one who thinks you don't have to test vaccines. There are a few politicians who might think that, but there are none of our participants here today. And there's Julia, great. So, great to see you. So you can see the basis. We have an audience of, sort of evenly split between people who are quite familiar and quite unfamiliar with how in the normal world vaccines are developed and tested and made available. But this isn't the normal world. And so Julia, let me start with you, because in addition to your role at MSD, you're head of the Vaccines Committee at the International Federation of Pharmaceutical Manufacturers and Associations, if I've got the title right, the IFPMA. So Julia, two things. We've seen an unprecedented level of collaboration between private sector companies and private and public sector companies. And secondly, we've seen a set of access principles that most of the major vaccine companies have signed up to. So tell us a bit about those, and then Isabel, I'll ask you to come in on that as well.
Sure, thank you, Mark. And I just want to thank everyone for the invitation to participate in this discussion today. You know, the first panel was I think very helpful in illuminating what some of the critical issues are in addressing this pandemic. And I think, you know, I can't underscore enough that this pandemic is unrivaled in the scientific and the global health and the programmatic challenges and demands for collaboration that it brings to the global community, and that a highly coordinated and collaborated global, regional, and local effort, it has been underway for quite some time, that has brought together industry, public agencies, multilateral organizations, financial institutions, governments, philanthropic foundations, and civil society in a partnership to harness our unique capabilities to develop, produce, and deploy COVID-19 vaccines. And as Mark mentioned, one of those critical partners is the International Federation of Pharmaceutical Manufacturers and Associations. And we have been working, Isabel and I and colleagues from the other member companies on our partnership with the ACT Accelerator and the COVAX facility for quite some time, and have developed a set of policy principles pretty early on in our response to the pandemic to show our support for end-to-end public-private partnerships that have resulted in the stand-up of the ACT Accelerator and the COVAX facility. And I think these principles really highlight the enabling policies that are necessary for access from R&D to manufacturing to allocation to use of COVID-19 vaccines. And Merck, individually and as a member of IFPMA,
is actively involved in and supportive of the goals of the COVAX pillar to accelerate development, production, and most importantly, global equitable access to COVID-19 vaccines. And we are also committed to working with governments and others to make our vaccines broadly accessible and affordable to the people who need them. We're really pleased to be a partner in what is a unique and I think really fundamentally different partnership with this initiative, and just thank CEPI, Gavi, the WHO, and all of the partners that are engaged in this. And we're hopeful that for the first time, this will make a really big difference in accelerating all of our work, because we believe that we're stronger, we're faster, and we're more effective in working together. And industry has not always been asked to be a partner at the table in this, and I'm sure you'll hear similar comments from Isabel when she speaks. And this has been a necessary but insufficient first step. And as we move forward, it's going to be even more important when we get into the details that were discussed in the first panel, that we continue to be a partner at the table, and that we continue to educate and engage on what some of the challenges are in manufacturing scale up and deployment, so that we're able to very, very quickly pivot and make changes where necessary to be able to get these products as quickly to people as possible once they are licensed and approved for use.
And actually, I'm going to come to you, Isabel, in just a second, but I'll come to Raul after that, because I know that you have some strong feelings about exactly this point on how early to bring industry in and how to make sure industry is more integrated. So I'll come to you in a second, Raul. But Isabel, you've been part of this group. Sanofi, for people who don't know, Sanofi and GSK are working together on COVID vaccines. And someone said to me that that's a bit like Coca-Cola and Pepsi-Cola working together to develop a new soft drink. These are kind of the two great historic rivals in routine immunization. So that gives us a flavor of how much collaboration is happening that hasn't happened before.
Yeah, thank you, Mark. Thank you, Elizabeth. Thanks a lot for the invitation first to this panel, and for the opportunity to talk about the work that we're doing. I'm not sure that as a vaccine manufacturer, being compared to Coca-Cola and Pepsi is something that makes me really happy. Talking about unprecedented cooperation, I think that's a really, really good example, Mark. Yeah, because in order to make this vaccine available worldwide, which is vaccine today admitted by most of the experts as the ultimate weapon to fight against COVID-19, I mean, the doses need to get out at a speed and scale that had never been contemplated before. There is no single company, there is no single vaccine that can achieve that alone. And this pandemic has revealed the world capacity for global cooperation. We saw that in the first panel. We saw our colleagues from global health actors that are teaming up today to speed up research, to speed up development for COVID vaccines. And both large and small companies and entities are also coming together to develop and to ramp up manufacturing capabilities. So an illustration, as you said, of companies partnering in an effort to give a vaccine to everyone is the unprecedented partnership between Sanofi, Pasteur, and GSK. And we came together to respond with a plan that leverage our industrial infrastructure and also our respective know-how of both companies. Sanofi will contribute, so we'll make the finished product, the final product, the vaccine at the end, and Sanofi will contribute with its recombinant DNA technology to produce the antigen, while GSK is bringing its adjuvant technology. And this is the first of both companies that are in effect competitors. And I must say that we had to be a bit creative about to make sure how we could advance this project in a fast but also compliant way, because as you can imagine, antitrust is everywhere each time we speak, being competitors on the market where this potential vaccine, this expected vaccine will be administered. So we are working very hard separately and all together to make that vaccine available, expected to be available by mid next year.
And I really want to come on to this question of speed and what can be speeded up and what can't. But Howell, let me bring you in on 2 points first. First of all, the point that Julia made about the need for industry to be involved and to be involved early. And I know you think that should extend to the alert systems that we use globally to detect pandemics and epidemics and outbreaks early. So let me ask you to comment on that. And then secondly, to Isabel's point about companies of different sizes. And I know you think it's important that regional players be involved in this process, again, from early on.
Thank you, Mark. Thank you, Elizabeth. And I am quite convinced that the partnership is a key condition for the development and to attend the demand, the world demand. No question about the need of partnership, and I keep saying here at our institute that we have to create competence to be able to be partner. This is a very specific condition, very special condition, that we have to be competent to become a productive and desired and partners. This is, and the second thing that you mentioned is the alert system. The alert system in the world, because if we have more collaboration, we can improve our alert condition and to respond faster and in better way. And as the interaction between private and public, we are a very good example. I have in Isabel and Julia, quite special partners of Butantan. We have with Sanofi and with Merck Sharp & Down, a very long and traditional relationship that we work together for many years. So, like for instance, Sanofi, we have for 20 years a collaboration, and that we celebrated this last year, 20 years of collaboration. And we are today, Sanofi released one very special issue about the extending more products that we have in mind to be collaborating. So collaboration, partnership, and improvement of alert. And also we have to have more regional capability. This is something that we're going to tend more the future demands that you're going to face for sure in the next years.
And those of you who are looking in the chat box will see that we put links to the organizations. Butantan is .gov.br. So we should say, shouldn't we, Professor, that Butantan is an institution of the government of the state of São Paulo, right?
Yes, it's a public institute that is like I said, is quite related to the private sector, because we need this type of collaboration, this kind of partnership to have to attend the public in Brazil, to attend the population, the Brazilian population.
Great. So let me come back to a point Julia started on, and that the three of you are really involved in, which is we hear a lot about things going at warp speed and unprecedented, twice as fast as any vaccine in history. And in the earlier panel and on polling we saw yesterday in the US, that seems to be unsettling people. People start to think, well, if something's quick, maybe it's not safe. Maybe we're cutting corners on vaccines that are going to leave us with products that are somehow dangerous or not fully tested. So I'd like to get the three of you to talk a bit about, because I know that all of you are involved in structuring and running both the early and the later clinical trials, where you can speed things up and where you can't. Isabel, let me start with you, and then I'll come to the other two, if I may. Isabel, I think you're on mute.
Yeah, sorry. So I start, and to my colleague Julia and Raul, and you will, I'm sure, complete. So first of all, I mean, when we think about the vaccines, we always say, and we know that it's between 10, 12, if it's a real innovation, can be 20 years to have the vaccine in the market. And here, in the case of COVID-19, we as manufacturer, depending on the vaccine, the project, and the technology, whether it's proven already or not, we're saying, okay, in 18 months, in 2 years, 18 months, let's say, we could have potentially a vaccine that is available for the population. How that's possible, and how we can envisage that, and what is the compromise that is made? Where is the compromise that is made? So first of all, I'd like to say that there are things that manufacturers can do and things that regulatory authorities and governments can do to accelerate the overall process. On the manufacturing side, there are, let's say, I will just put two things and let my colleagues complete. The first one is that we are designing research and development plan for maximum speed, meaning there is a single global clinical development plan. So there is no specific country trials for national registration. It's not compatible with a pandemic program. We are choosing countries that we include in the multinational trials based on epidemiology, of course, but we are selecting them with their regulatory speed, their operational feasibility to run such trials, and also for rapid enrollment. And we will, in a single phase 3, big phase 3 trials, I mean, all of us have almost 30,000 patients in the phase 3, will target geographical breadth, north, south, east, west, population diversity. So everything done for R&D in one shot. At the same time, as we are building this clinical development and clinical data, we are building the manufacturing capabilities at risk. It doesn't happen for a regular vaccine. We are advancing the steps in parallel that would normally be done sequentially. We are starting manufacturing scale-up step, including process validation at risk. We are starting industrial scale activities in parallel of clinical studies where we have all uncertainties. We don't know the yield, we don't know the content per dose, we don't know the final schedule, we don't know the efficacy, but we are building the maximum capacity at the moment. And this goes with probably what we will discuss later, because it was a big topic on the first panel, is where do we get the funding in order to de-risk that approach, because no single company can absorb that. So that's basically what we can say from our side, but zero compromise on quality, safety, and efficacy. That's the main message. On the side of the authorities and agencies, they can also accelerate what can be done in terms of review, all the administrative steps for clinical trial applications, for regulatory review, accepting rolling submissions, so they review the data as they come, not waiting for the final data package to be available, etc. There are a lot of things that can be done. And for government and public health agencies, all the policies, the vaccination policies that can be reflected in parallel of the development, not waiting for having the finished product with all the characteristics to decide how this vaccine will be administered. So everybody has a role to play in this overall acceleration, but today I want to reassure everyone that no one will make any compromise on the assessment. So for us, generation of data, and for regulatory agency in the assessment regarding the data that are required for a vaccine regarding quality, safety, and efficacy of the finished product.
So as Arnaud was saying on the last panel, you're effectively building factories for vaccines, most of which won't work, and then it requires 6 months or a year to repurpose that factory to make another vaccine. So this is an enormous sort of planned inefficient spending that under normal circumstances wouldn't be possible, but in the context of this this pandemic is. The Slido here, remember you can ask questions, you can vote on other people's questions, and we have a question that Julia, it won't be all of your answer, but I'd like you to include in your answer if you would. Martin Coleman says, speedily manufacturing and developing these vaccines for global distribution will require innovation on patent rights, won't it? So can you address that and then also build on what Isabel has just said?
Sure, I'm happy to take that one, and maybe just to start off and build a little bit on what Isabel, I think, very eloquently laid out, and I will reiterate again what she reiterated, which is, you know, any sort of acceleration or efficiency we gain in time will not mean that a less safe or less efficacious vaccine will be at the end of that process. Safety and quality are the goals here. And you know, when you put speed in, that means that some other things then get left behind. And one of those is resource efficiency. And so just a couple of examples of ways that you might do something in a stepwise fashion, but now you're doing it at the same time, even in the preclinical phase, where you're looking at what is the candidate that you're going to put forward into human trials. You may test one in a roller bottle, and then if that doesn't work, then you test another one, you test another one, and you might go through 10. We may be doing that all at the same time, because we don't have time to wait, even if it's just days, to see whether or not we're getting what we want out of that first test. And when you multiply that by the number of steps that you take in the preclinical and clinical process to get to the right formulation and the right characteristics, then you can see very rapidly how resource inefficiency it becomes a huge challenge here. And then, you know, also to Isabel's points around manufacturing, you know, just maybe a couple of examples from our work in developing our Ebola vaccine, or VIVO. You know, the clinical development work was actually done many years before we got final licensure, because you license not just the product, but you license the manufacturing facility in vaccines. And I know many people on the line know that, but for those who are less familiar with the process, and you have to develop assays, and you have quality tests that have to be run, and then you have inspections from regulators. And if you have 100+ countries that you're going to be exporting these vaccines to, then each one of them wants to come in and inspect your facility. Every time you do that, you have to stop what you're doing. And we had a really wonderful experience when we were developing the commercial manufacturing facility for VIVO, where FDA, EMA, and through WHO, AVRF, which is the African Regulatory Federation, we all worked together to try to streamline and create, you know, more standardized systematic approaches, so that we were able to do the work we needed to do, and very, very quickly the regulators got the information that they needed. And what that resulted in was, I think, an unprecedented speed from finished filing to approvals, as well as pre-qualification from WHO and regulatory approvals in African countries that typically take a decade or more, were happening in weeks, if not days, after those initial regulatory approvals. So it can be done, and it's even more important in this global context than it was with Ebola in one region of the world. And so I think, you know, to underscore Isabel's points, there's work that we can do and that we are doing as developers and manufacturers to speed up this work. And at the same time, there's a lot that needs to happen very, very tactically with regulators and others who are in the policy space, to ensure that together we're able to save as many weeks and days as we possibly can with these products. And one of the ways that we're able to do that as quickly as possible is to be able to ensure that we have partnerships that respect our intellectual property and our know-how. And looking at Raul, we have a long-standing partnership with them on the making available our HPV vaccine in Brazil. That took a long time, and I know that Raul will agree with me, a lot of day-to-day work, rolling up your sleeves and working together on transferring that technology. And that was done because we both have a respect for and protection of our intellectual property and know-how, and it's done in a way that is strategic and in the end ultimately increases access. And I think the critical point here is that we have networks and we have partnerships, whether that's on the clinical side or on the manufacturing side, and that we understand how best as organizations to tap into the expertise that is going to enable global access to these products.
So Julia, I want to ask Raul, does he agree with you first? And then I know, Raul, you think that there needs to be more tech transfer to regional producers such as Butantan, who can supply within their own region and indeed run clinical trials within their own region. So first of all, come in on that intellectual property point that Martin raised, and then the broader issue, if you would.
Okay, I'll start saying that I completely agree with Julia and Isabel, and I have a very few additional comments, but I would reiterate that the trust, the mutual respect that we grow, that we share, it's quite important for the relationship in the partnership. And the regulatory agencies are going to play a very important, because of course we are facing unprecedented situation. It is unprecedented. Things that could be shorter, could be improved in terms of time. It is quite necessary at this point. And the regulatory going to have the task to balance quality, safety, and speed. That's not easy. That's not easy. But another point, a very important point, is the companies are at the same time taking care of the factory and the clinical and the research, the science. It is quite a challenge to combine all these three initiatives at the same time. Of course, we are in some cases we are more advanced, but like in Butantan, we try to separate the company facility, the facilities at the factory to the clinical trials or the research. Otherwise, we're not going to get any result. This is quite important. Back to the point that we have to have more collaboration. Of course, more and more collaboration gonna come, gonna need, and we are very confident that this situation promote the necessary share of technology and the necessary share of production system to attend the needs of the population. This is quite clear for me, Mark.
So Dale Hill has asked a really interesting question. All of you have been talking about we're doing these things in parallel, no compromises on safety, no compromises on efficacy. We save time because you were saying, Raul, you're doing manufacturing and research in parallel. You were saying much the same thing, Isabel. So Dale says, great, but won't that affect the eventual coverage and access because the costs are going to be so much higher? And I think it ties to your earlier point, Isabel, about who's going to fund eventual access, and how do the manufacturers know that even if products are quite expensive, there'll be purchases for them?
Yeah. So there's a lot of point behind. So let me let me try to address them. If I'm missing one, please feel free to bring me back to what really you expect there. And first, to go straight to the point on is doing everything, what the consequence on the price and so on. I will explain how we are de-risking this financial approach, because today, and I'm speaking for Sanofi, we would have never taken the financial risk to do that by ourselves and reflecting that on our price. So that's not at all the approach. On the access, we do not believe that our company should be the one deciding on the allocation of all vaccines, of all doses once they are available. But building on that, we have to find the right balance between getting appropriate funding through bilateral deals very early in the development, while managing the global and equitable access for this vaccine. The global need for COVID-19 vaccine, we said that already, is unprecedented, unparalleled, requiring investment for accelerating, I explained that, innovation, accelerating, ramping up vaccine manufacturing capacities, all these activities with significant financial risk. I said that already. And Sanofi, like any other manufacturer, we are receiving requests from individual governments from all around the world and procurement partners for doses to be delivered as soon as possible. What can we do to help you, Sanofi, to accelerate everything, because we want doses as early as possible. But we cannot engage in bilateral negotiations with all the countries right away. That's not possible. We believe that we have the responsibility to supply in a way that is both pragmatic and ethical. So pragmatic, I mean, and I said that already, we had to build an industrial plan with leverage our existing industrial infrastructure that is relevant for COVID-19, technology and know-how in order to manufacture the largest number of doses. We are targeting something like 1 billion at the moment, as soon as possible in 2021. Sharing the risk with governments and agencies for building this appropriate capacity is a condition allowing to undertake substantial investment of resources for clinical trial development and for industrial capacity. And in return of these investments, understandably, governments expect to secure quantity of vaccines for their own population. And this has driven, for us, Sanofi and GSK, limited but very early discussion with governments like the US, like Europe, like UK. You saw that it's publicly announced now. Why those countries? Because, and for some of them, we have long-standing contract, partnership, investment, building pandemic preparedness. And that's a point that we can just keep in mind, because everything we are doing that at one point of time, we will have to build lessons for the next one. So having a pandemic preparedness policy and approach is something very important. Some governments, like the US, they have it. And on the other side, our commitment is to make, so we have these bilateral deals with quantities of vaccines that are secured, let's say reserved. Not sure they will use it because there are some little bit of overbooking, not knowing which vaccine will be a success. On the other side, our commitment is to make our vaccine available to all. And the global pool procurement mechanism being set up under the COVAX, that was very well presented by our colleagues from Gavi and CEPI, so the COVAX facility, offers a way to make our doses available to participate in countries, to participate in countries in an efficient way. And this mechanism will help avoiding inequalities. So we are committed to reserve a volume of our doses and to make this volume of doses available for COVAX for the global access. So Arnaud was quite vocal on the first panel about everything is booked, etc. No, not everything is booked, but we are in the middle of that and we have to manage both. Finding funding in order to make sure we can do that very quickly. And it started very, very early, very, very early, even before the setup of the COVAX architecture, how you call that in the first panel. And on the other side, making sure that some doses are reserved for the global access.
Julia, just before I come to you, a quick reminder that we have about 15 minutes left, well, a little bit less, but time for your questions. So slido.com, use the QR code or the number and ask a question if you would like us to address it. So Julia, I think Isabel did a masterful job of covering the long list there, but ultimately these will be quite, I mean, the use of resource means that these vaccines are not going to be cheap. And countries do need to make advanced commitments. Do you occasionally, as a manufacturer, feel squeezed in between the various different ways that countries are making those commitments?
Absolutely. And I think Isabel did a really nice job of explaining what some of those challenges are. And what this all exposes is that our health security and our preparedness innovation ecosystem needs a lot of work. And, you know, what we're all doing right now, whether it's with our clinical development, you know, certainly for Merck, trying to choose proven platforms that will enable us to move as quickly as possible, or leveraging our existing manufacturing footprint and networks, because we need to scale up manufacturing as quickly as possible, that we're doing what we have to do because we're in the situation that we're in right now as a global community. But if we had a more robust health security innovation and preparedness ecosystem, that we would not probably be in this same situation, because we would have a broader set of capacities and capabilities, whether that was from a clinical development, a manufacturer, or deployment on the ground in countries. And so I think, you know, as we consider how we look on the other side of this, that, you know, that this pandemic is really exposing some important fissures and cracks in this ecosystem, and that we need to look at it from an upstream and a downstream perspective, and trying to figure out what we need to do as a global community going forward. And I think
so sorry to interrupt you. By upstream, you mean the R&D part. By downstream, you mean manufacturing distribution.
Manufacturing and distribution, exactly. And so, you know, and I think manufacturing kind of spans the two, that there need to be more sustained enabling pathways for innovation and for creating the kind of flexible manufacturing capacity that you could leverage in an epidemic, an outbreak, or a pandemic situation. And we don't have that now. We have a few organizations and a few governments that have made those investments as an insurance policy. But for the most part, there isn't a market for that kind of work, or there's a very little market for that kind of work. And so, you know, of all of the unmet medical needs, it's very challenging for companies to be able to go all in on that without the right kind of risk sharing and incentives to do that. And then on the downstream side, we really need to invest more and build resilient health systems that can facilitate the kind of public health measures that we need before medicines and vaccines are available, and then be able to deliver and administer vaccines and medicines once they are available. And so I don't want us to forget about this idea that, you know, breakthrough and incremental innovation is critically important for us to be able to do this better next time, so that we can be more efficient, and that at the end of the day, our products and our pricing models can show that that risk sharing and that sustained investment, and at the same time recognizing that that's only part of the solution, and the other part of the solution has to be about ensuring that the health systems are able to deliver on the products that we're bringing forward as innovative companies.
So Howell, I want you to pick up on this because you're in a really interesting region. You're in a region where health is intensely politicized. The focus of massive constitutional, legal, political arguments, and yet in a region in which governments, or some governments, let's not say all, have historically been unwilling to make these sort of advanced commitments. So how do you see this as a Latin American playing out, this tension about advanced commitments, immediate needs, preparation for the longer term? Howell, you're on mute, I think.
Okay.
Perfect. There we are.
Okay. You mean it is a big challenge for Latin America. Of course, we see some efforts here in a few countries around South America and also Mexico. They are trying to improve their production to provide regional access. In terms of Brazil, the access, it will be a free access. It's a different story because we're going to provide the government, and the government going to provide the population the access to the vaccine. But in terms of Latin America, of course, we have lots of countries expressing and trying to bring the trials, trying to bring several trials for clinical trials for the countries. And of course, they are really interested in to have some amount of vaccines as a consequence of it. And at the same time, we are establishing one of the very important step for us, Fiocruz and Butantan, is to establish a competence with the transference of technology to provide regional and to provide the country, and maybe collaboration, if we do have this possibility in the future, to provide regional supply for other countries in Latin America or South America. This is back a little bit to the resources, that is the funding that Isabel and Julia said. It is quite important that we can see several endowments around the world that's quite important endowments that is supplying lots of initiatives in terms of research, in terms of production. This is again unprecedented. Large companies, large fortunes that is providing endowments. And of course, organizations, international organizations, get more organized to provide resource. And of course, in some countries more than others, public support, government support for development, and it is also happening.
I just want to ask you one more question. I mean, that both Isabel and Julia touched on, which and that Chesley Atchison asked about, the regulatory challenges. So I think it's fair to say that some Latin American regulators are not known for their flexibility, right? They have their way of doing things and they like to do it that way. Do you see regulators within your region and beyond being able to meet the challenges of, once the data are there to show safety and efficacy, moving at the necessary speed to license?
Yeah, talking about the regulatory in Brazil, the regulatory agencies in Brazil, Anvisa, that you all know, it is a very qualified agency, and they are doing a very extraordinary effort to provide necessary support to make it as possible, as fast as possible. But always security is quite. It's quite a point for us and for them. Okay, this is we are quite confident in our agency.
And I think Isabel and Julia, you'd echo that, right? That globally, we are seeing agencies saying we'll move at the fastest speed possible, but there's no question that we're going to approve something without a very, very solid basis of evidence.
Yeah, correct. And again, I repeat, we strongly support the importance of this rigorous scientific review of safety and efficacy. And we are calling on region and national agencies to work as fast as science and to collaborate to make sure to avoid redundant review of dossiers that we will submit everywhere. I mean, the WHO will have a role here with the pre-qualification to make sure that we have a sort of reference and standards approval for countries that have programmatic specificities compared to what the US or Europe agencies could also approve. But overall, this is another type of collaboration that will be required in order to make all those vaccines, all of those that will be successful, available to people who need them as soon as they are available.
Our time is almost gone, but Julia, just before it goes, I want to ask you to do something that sounds a bit odd, to think past the time when we have the first vaccines. And Isabel earlier mentioned incremental innovation. So the job isn't over when we have the first, or it's highly unlikely to be over when we have the first vaccines, right?
Yeah, absolutely. And, you know, as I mentioned in my earlier remarks, the goal right now is quality, safety, and efficacy. But that means that the cold chain footprint might not be exactly what we would all want. The dosing and administration, the indication, and so, you know, very much like we saw with our Ervivo development process, there's more work that has to be done once you get that initial product to licensure to try to improve the storage requirements, to try to improve the dosing. You know, to add pregnant women or you know, other age cohorts to this. And so that work has to continue. And I think if I could just get one more plug in on regulatory quickly, if I could talk to the regulators about this issue as well as what we're doing now as a group, I would say thank you for everything that you're doing so far. More needs to be done pre-licensure, but a lot will need to be done post-licensure because we're going to want to make post-approval changes. And that is something that can take years and years and years and years to do. And so that, you know, that's really an avenue that needs to be opened up for us as we're thinking about what happens after that first wave of vaccines, if it's our vaccine or somebody else's vaccines are available. Oh, you're on mute, Mark.
Yes.
Yeah.
My snoring dog, I keep muting myself. It's been a wonderful discussion. And like the first session, I just find myself wishing we had another hour, but we don't. The discussion will go on the PQMD forum. So please do post questions and comments there. People will be watching this, so typically I'm told we get many more people watching delayed than participate live. And so those of you watching on delay, I would encourage you to go to the practice forum and post comments and questions, which we'll do our best to deal with, and we'll put the link there. But I think for now, and I've posted a question, I've posted one final question, which you're free to answer, and you'll see the answers if you go to the Slido site about, yes, there's the final question. So you can, this comes from a famous story of a British lawyer and a British judge. So you can answer the question and say whether you feel you're better informed or you understand it better or both. Anyway, I would really like to thank my panel who've made this one of the fastest hours in my life. So if I could thank Isabel Deschamps of Sanofi Pasteur, Professor Raul Machado Neto of the Instituto Butantan, and Dr. Julia Spencer of Merck MSD and the Vaccines Committee of the IFPMA. Really do appreciate you taking the time and making such wonderful contributions. EJ, I know you have a couple of words you want to pass on, right?
Yes, yes. Thank you so much. Thank you, Mark, and all the panelists from both panels for lending your expertise in discussion. The world is pinning its hopes on return to normalcy, on the creation of a vaccine, and we have certainly learned how complicated that can truly be. I also would like to give a special thanks to Alyssa Prechep and Arno Bernard from the World Economic Forum, whose time and thought was really essential to this event. I also just wanted, while we have a few of you left on the line, I just wanted to let you know that we've got some webinars that are coming up. The Global Health Security webinar is on September 17th, so mark your calendars. And then there will be additional webinars on rare diseases, supply chain, therapeutics, and mental health. So obviously COVID will be woven into those, and we do have a partnership with the World Economic Forum to continue to bring you this high level of really fantastic speakers and panelists. And a full calendar of those can be found on our Community of Practice on the events page, and also on the Pillar Talks tab on our website. So on behalf of PQMD, thank you all for being with us today and for the work you do in the world that brought you to this event. Please keep an eye out for our notices and our monthly webinars, and stay safe and healthy, and enjoy the rest of your day.